Now it's my pleasure to invite Dr. Rajiv Choudhary for his presentation on subluxated cataract.
Good morning, friends, and thanks to Dr. Hermans for inviting me for this course. My topic is subluxated cataract. As we know, there is a surgical management of cataract associated with jonular dialysis. It's one of the difficult situations for the phacosurgeon, and it is a real challenge for the ophthalmic surgeon. There are multiple causes: traumatic, spontaneous, hereditary, systemic association. And management is varying comprehensive. Can I have the pointer? Yes. Comprehensive preoperative evaluation and assessing the area of weak jonular area and whether the vitreous is in the anterior chamber is there or not. So you can plan. So they are short in summary that if the area of jonular dialysis is 3 o'clock, 5 o'clock, 5 to 7 o'clock, so you can plan accordingly, whether it's 5, 7, or more than that. So whether you want to CTR without CTR, or switching the CTR, or you have to go for glued IOL, or so basic is the incision should be away from the area of jonular weakness, smallest possible incision. Begins capsulorhexis should be starting from the begins in the area of remote from the dialysis, and should be ideal side 5.5 to 6 because you may have to put the lens on the capsular bag. And in case of external jonular weakness, it should be done by the blade because with the forceps and sometimes you give more stretch on the jonules. Hydrodissection should be careful, nucleus freed maximally, parameter should be low, and divide and chop technique is preferred. Cortical viscodissection reduces the stress on the jonules. Manual aspiration is preferred sometime. Aim is to achieve the IOL centration and long-term stability. So there are the some videos. It's a jonular dialysis is a less than 3 o'clock hour, where is some freeing of the capsule. So start away, then rhexis, and once use the good viscoelastic, as the hypermature cataract, Morgagnian, using the low parameter, avoid the turbulence in the anterior chamber, so it will not increase your dialysis, and we can finish the surgery, maintaining the good anterior chamber depth, using good viscoelastic because the turbulence should be avoided. Repeated injection of the viscoelastic. Keep your chamber inflated and put the lens haptics at the direction of the subluxation. So it will give S and it will avoid the decentration. If it is more than 5 o'clock hours, you can use the CTR. CTR can be placed before or after the bag, preferably before nucleus fragmentation. Then we can move on, and the management is easy. We'll go for another good video. This is extension more than 7 o'clock. We use the capsular hook. Try to do the rhexis. One of the important point, use the good viscot, so avoid the fragmentation falling into the vitreous. Because the dialysis is much more, we try to debulk the nucleus, but the turbulence was much more. So we used the capsular hook to stabilize the bag. 2 hooks. So once it stabilizes with the bag, your bag is stable, we can perform the rhexis very well. Nucleus management with the low power, low parameters, so turbulence will be, skip. And once you remove this, you need the CTR. Suturing the CTR is must for these cases. We have to suture the CTR, the one area, and then put the lens and remove the bag. Now, in case of extremely loose, there is a multiple option of iris fixated, glues IOL, anti-chamber IOL. I will go for, we skip the glued IOL. This is the iris claw, the subluxated Morphin syndrome. Remove the lensectomy done. We'll skip. Okay. So I will show you the steps of the inclination. This is the important. Once you're done, the friends, this how simple it is to put the iris claw. Another main important is the holding of the iris claw from this point steady, because once you claw, it will give a pressure on the forceps, and once it is clawed, you can see a central. Another, the use of the femtocataract in doing the rhexis. This is one of the advantage of the femtocataract. We can get a good rhexis in without creating any stress on the granules. Once you have done this, put the remove and suturing the CTR in the bag, fast formatting, and once you suture, you can put the lens. In short, this is the, and one of the option, because the armor is here, I want to show the glued IOL is the option for managing the simple steps, is one of the good option to give a 2 claw enclaved on this side and putting the lens into the scleral pockets, and this is the infusion created to maintain the chamber, and probably it is the well centered and stabilize the lenses. So in short, recent advances in equipment and instrumentation, better understanding of fluidics, give a relatively safe cataract surgery even in the subluxated cataracts. Thank you.